Okay. Polls would be conducted, and I want all of you to participate in the polls. Okay, so these are all clinical cases where there are big MCQs of 4-5 lines. Okay, we have a village worker Asha who is demonstrating contraceptive technique, and for the group, okay, for the barrier contraception, and she explains that the vaginal diaphragm should be removed when after the intercourse, after 1 hour, after 24 hours, after 6 to 8 hours, or immediately. Okay, so they're asking us something about vaginal diaphragm. Okay, uh, and last 20 seconds, so please participate. Right, wrong does not matter, even those who are joining in now. Saheli, Anirudh, Shivansh, Urvi. Okay, all those are joining in now also, please participate. Right, wrong does not matter. Okay, happy 70% of you are getting it correct. And as usual, we not only discuss this one MCQ, lots of point around this MCQ also I will tell you, so that you get lots of benefit. Okay, last 10 seconds. Yes, around 7. Okay. Those who are joining in now also quickly, Janu, Shakti, Dr. Anjana, try to answer the question quickly. Okay, Simarpreet, PS. Okay, so yes. Okay, so now please pay attention. Yeah, okay, yeah. So all of you, point number 1, what is the difference? First, start counting the number of MCQ. This question I'll answer you in some time. Anybody, what is the difference between female condom and a diaphragm? Female condom and diaphragm, they are same or they are different? Okay, by the way, female condom is called as femidome. Femidome is the name. The other thing is it is marketed as the word reality. So you can remember, because years lots of many years ago the female condom was not available, so we jokingly tell the student, now remember that female condom is a reality and now female condom is available. Okay, very good. Shweta and Radio Mania, they are completely different. Please understand the difference. Let's say the female condom, outer ring and inner ring. Female condom is made of a sheath, outer ring open, inner ring closed. Please don't use it ulta, वरना problem हो जाएगा. And sir, the female condom covers the whole length of vagina. Both are barrier methods. Female condom covers the whole length of the vagina. Then here is the uterus, and here is the cervix, and here is where we place the diaphragm. So the most important difference between the two, that sir, the location is different. Where is our female condom? Sir, female condom is covering the vagina. Of course, sir, the diaphragm is also in the vagina. The diaphragm is mainly covering the cervix. Is this understood to all of you? Clap if you feel happy. 2 more MCQs also about the failure rate. Female condom, what is the failure rate? Anybody? What's the failure rate of female condom? And what is the failure? Yeah, very good, Maki. Around 18 to 20% is what you remember. These are very important. You can also get match the column. Yes, and diaphragm has got still higher failure rate, 18 to 28%. Remember, the main role of diaphragm is to hold the spermicidal agent. And clap if you feel happy. This is the image. This is the image of all your diaphragm. Okay, so this image based question also, please keep in mind, this picture should be imprinted in your brain. Okay, so you can see, like I say, like my students, katori, you can see like a vati. It's a small vati like thing. All of you can see this. So it's like a small cup or saucer, and in which you can put the spermicidal agent, and you can use it. Mother, the female can put it in the vagina. They can be inserted anytime before the intercourse, but you should not immediately remove it after the act of sex. So not immediately, not in 1 hour. Very good. The correct answer, majority have got it, after 6 to 8 hours. Perfectly correct. You should keep it. And lady can have sexual activity multiple times also in that period also, and maximum she can use it up to 24 hours. Very good. Somebody has already said about it that if we use it more than 24 hours, there's theoretically a risk of, yes, toxic shock syndrome. So this is also very important MCQ. Yes, all of you perfectly correct. Those who subscribed and heard my classes, absolutely correct. You are remembering things. Okay, so max 24 hours, 1 MCQ, 6 to 8 hours removed. Second MCQ, long term rakha. TSS, third MCQ, fourth MCQ, the location, and another this and this is this. Okay, now the last thing which I want to clarify is, anybody, there is a vaginal sponge available with the brand name of Today. Now what is this vaginal sponge? That is also to be squeezed and put in the vagina. So how does the vaginal sponge differ from our diaphragm? Okay, perfectly correct. So diaphragm is mainly a barrier method of birth control, and Today is a vaginal sponge, but it is not barrier. No, beta, Today is not weekly, Maki. Today is every time. It is called Today, but you will use it every time. Okay, you will use it on the day. You will use it today. Always you will use it today, matlab tonight. Okay, day and night depending on the sex, whenever today or tonight. Okay, but yes, very good, all of you. It contains a spermicidal agent. Okay, and that all of you have written nonoxynol 9. Okay, so please do not get confused. So Today is spermicidal agent, nonoxynol 9, diaphragm is a barrier method. Is this understood to all of you? And please last time see the picture of the diaphragm also for the upcoming entrance examination. Okay, again very important MCQ, something I'm giving you a clue based on our physiological changes during pregnancy. The poll has started. We have got a primigravida patient who has some complication. So see, all this upper part is just to confuse the student, does not matter. All of the following are warrant further investigation, except matlab, all of the following you would want to do some further investigations, except which one? Matlab, indirectly what they are asking you is, all of the following are pathological except which is acceptable. The question is which is acceptable to have. I should have given you slightly more time, but no problem. Next time I'll give you more time. Yes, very good, Shivani, perfectly that summarized it. That, sir, the question is which is physiological and which is pathological. Okay, this also is taught to you in medicine also. So now please pay attention. Please pay attention. 2-3 things. This is given. Okay, which are pathology, because in pregnancy also there are lots of changes. Okay, pregnancy also there are lots of changes which can happen in the body of the female. Okay, so this is given. I want all of you to remember this word, Metcalfe's criteria. Clap if you have learned something new on Saturday evening. Metcalfe's criteria. Metcalfe's criteria are conditions for pathological, which are always pathological. That is a criteria. So in that, remember Metcalfe's word, you may just want to remember. Okay, but even if you don't remember the name, it's okay. So remember all this. I'm giving you, apart from this, 3 will be the answers. 3 answers are there. One is normal, which is normal, I'll tell you in a minute. Answer is not yet been given. I'm giving you list, so you'll be knowing 7 to 8 more MCQs. Okay, cyanosis always pathological. You can't say, okay, just because she's cyanosis, it is okay. Anyone else? Can you tell me some other pathological things, like which is dangerous? I cannot neglect it. Okay, I cannot neglect it. Okay, so pathological cyanosis. What else? Raised JVP. Okay, raised, like example, edema feet. Edema feet is non-specific. Lots of pregnant lady get. Anybody? Why do we get edema feet in pregnancy? Why do we get edema feet in pregnancy? Chalo, again physiological. Why? Of course, it could be pathological. Yes, because perfectly correct, sir. Hypoproteinemia and all your compression of the IVC can cause edema, which is generally leg elevation pe chala jata hai. So edema can be considered. Okay. Very good. So mammary souffle or a systolic murmur, all that, but great that. Okay, so cyanosis dangerous, raised GVP dangerous. Very good. Diastolic murmur is always pathological, and similarly systolic. Very good, Swapna. Okay, yes, Jaya, fabulous. Okay, clubbing again, very good. Clubbing, you don't get pregnancy में clubbing. Okay, and similarly systolic murmur, which are more than grade 3/6. Okay, so mammary murmur, because to the breast the blood supplies increase, so that's called mammary souffle. Okay, that can be considered. Okay, okay, so all this cyanosis, raised GVP, diastolic murmur, clubbing, Okay, orthopneids, all that are, yes, very good, perfectly correct. All these are normal. So mid diastolic murmur aa gaya. Similarly, atrial fibrillation cannot be accepted. And similarly, cardiomegaly. Anybody, this is basically taught to us in our first day of medicine class. Why? Because, sir, of the diaphragm, as the pregnancy will become big, 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 the diaphragm elevation, our apex beat or apical impacts is going to be shifted laterally and upwards. Is this understood to all of you? So all of the following, this is a simple way of asking. This is a prime example how we can make a simple MCQ into a complicated MCQ. Like it could be also one-liner MCQ that all are physiological in pregnancy except, or all are pathological in pregnancy except. But see how they turn the question, and all this extra history has been given just to confuse the poor student. The 32 weeks hai, pedal edema hai, all of the following. So remember, atrial fibrillation dangerous. Okay, so we're going to add AFib also to our this. Okay, right axis, left axis deviation can be considered normal, LAD. Okay, LAD normal, edema normal, mammary murmur normal, cyanosis clubbing, raised GVP, diastolic murmur, all is yes. And similarly, very good, perfectly correct. Cardiomegaly is always pathological. Cardiomegaly pathological, and that is also in our list. Okay, so this goes by the name of Metcalfe's criteria, which you should keep in mind. Okay, is it understood to all of you? Those who are joining in late, Pallavi, Krishna, and Dr. MDRD, go back and see the recordings also, which you could have missed in the first 15 minutes. Okay, yes. One more important MCQ, clinical case-based scenario. Read the question correctly and all of you please answer. We have got a lady who is 48. Always look at the age of the patient in the MCQ first. Okay, heavy menstrual bleeding, that is indirectly what? A patient of menorrhagia. Menorrhagia, another word is heavy menstrual bleeding, HMB. It's a newer word to use for menorrhagia. Okay, is it understood to all of you? Then there is some scan done and aspiration, simple endometrial hyperplasia with urticipia, which is the most appropriate management for this patient. Okay, those who are joining in now, Jyoti, Sai, also please try to answer. So with every MCQ, we are giving you lots of extra points and not just discussing that answer only. Okay. Last, yeah, Shivans, very good, very well spotted the main important point. Yes, so please keep in mind that point number one, I have a 48-year-old lady, so who is perimenopausal or 40 plus. Okay, now whenever there is a lady who is 40, 45 plus with menorrhagia, we should always, always, always don't directly jump to the treatment, so hysterectomy, progesterone. Treatment we will discuss. First, you should always do what? Anybody, if I have any patient who is perimenopausal with our heavy menstrual bleeding or menorrhagia, very good. Pre, Jaya, all of you, yes, we should always, always, always rule out endometrial hyperplasia, endometrial cancer. And how? Please understand, on sonography you cannot. How can I come to know on sonography hyperplasia? That's a mistake of the student. Is anybody, can ultrasonography tell me that there is hyperplasia? Yes, no, never, no. Please understand this. Sonography can only tell you, no, Varun, please understand, yes, sonography can only tell me thickened endometrium. Or Varun, jo aap bol rahe ho, thickness more than 4 millimeters is only the criteria for postmenopausal age group. Here we are not postmenopausal, we are still perimenopausal. Is this understood? So very good, Ambika PDU. It's an ultrasonography can at the most tell us it is a thickened endometrium. But that does not mean thickened endometrium always does not mean hyperplasia. This is a pathology concept. It's a hyperplasia and cancer is the diagnosis under the microscope. Only on histopathology can I label the patient. So directly by looking at the patient, I can't say, okay, oh, you have got hyperplasia, you have got cancer, you go for surgery directly. Is it understood? So I want all of you, and this MCQ is coming for sure. Take it from me on the 11th September exam. You will thank me like every time I get lots of emails from the students. This MCQ is coming for sure in this 11th September examination. That whenever I have a perimenopausal who is having menorrhagia, फर्स्ट थिंग रिमेंबर, एक टुकड़ा लाइनिंग का माइक्रोस्कोप के नीचे आना चाहिए. शायरी को ध्यान से सुनिए, एक टुकड़ा लाइनिंग का माइक्रोस्कोप के नीचे आना चाहिए. मतलब ऑल ऑफ यू विल राइट डाउन HPE is mandatory. Okay, what is HPE? Histopathological examination of the endometrium is compulsory, which could be done either by doing DNC, very good, or which could be done by doing endometrial biopsy. Both mean the same thing, almost similar, but it's a technique to do HPE, and that was in fact done. So it's a very good thing that even though sonography is normal, so sonography is normal, still endometrial aspiration was shown. Okay, now the endometrial hyperplasia with atypia. So anybody, this DNC or endometrial biopsy is showing us hyperplasia with atypia. Anybody, is this dangerous? Not dangerous? What should I do? Okay, and they've said simple hyperplasia. Yes, so please understand, simple hyperplasia can develop into cancer. Complex can also develop, but when there is atypia, there is more chance of developing into cancer. Very good, all of you. So when atypia is there, still it's not 40-50%, it's only 3%. Okay, 8%, 10%, 20%, but atypia जो है simple hyperplasia with atypia roughly 8 to 10% chance of becoming malignancy. 13829. Okay, so please understand this, that here I cannot go for only observation or wait and watch. This is out. Yes or no? Do you agree with me or not? This is out. Okay, and very good, the best management or the most appropriate is to go and remove the uterus. However, as I told you, this is the last resort, we remove the uterus, but in this case it is absolutely warranted, because we should always try to save the uterus. Yes or no? Like save the mother, save the baby. Indian government bolta hai save the tiger, so let's save the tiger, and gynecologists should say let's save the uterus. So yes, we should save the uterus, but unfortunately in this case we cannot. Yes, beta, yes Jaya, so the next best or the next most appropriate would be hysterectomy only. Okay, yes, so please understand this, okay, hysterectomy is the best option, and only anybody, what hysterectomy will I do? Will I do, tell me, will I do radical hysterectomy? Will I do modified radical hysterectomy? Will I do mixed hysterectomy? Or will I do simple hysterectomy? Very good, all of you, you can see all of you, I'm so happy. Dil se dua nikal, all of you have been doing fabulous revision for your upcoming NEET PG. That only simple hysterectomy is more than enough. Please understand, simple matlab it is not simple to perform. Okay, but simple ka matlab hai ke what I do, no beta part th nahi, see now compulsory, it is simple. Now simple hysterectomy could be TLH, total laparoscopic hysterectomy. Yes, total abdominal hysterectomy, or even vaginal hysterectomy. Whatever route you do, route is left upon the surgeon expertise. Only the uterus and the cervix will come out of the body. No need to remove lymph nodes, parametrium. Don't even remove the ovaries. Never remove the ovaries in a this one unless they are pathological, okay, or unless they are showing some problem, because otherwise the lady becomes surgical menopause. So only the uterus I will remove. That is the meaning of simple hysterectomy. Okay, so whatever route is not important. Simple hysterectomy could be done through the abdominal route. laparoscopic route or vaginal route. Is this understood to all of you? Now, if the same MCQ, ध्यान से सुनना, that is one option. But instead of 48-year-old, I have got a 25, 26 years old, okay, 30-year-old patient with simple hyperplasia or even complex hyperplasia. What will I do? Very good, sir. Here, progesterone, because underline boldly 3 times. Progesterone is for both prevention and treatment of hyperplasia. Very good. Anything. Okay. Not Ambika, not LEAP, not LEAP. But a LEAP is for cervical cancer. Okay, Ambika. Yes. Ranjana, correct. So please understand. Now progesterone. Now this progesterone could be tablets also. I could give progesterone tablets. I could give progesterone injection, and of course I can go for LNG, IUD, or what all of you are telling me, Mirena insertion. No beta, eyes on premenopausal, there is no cutoff, because in premenopausal eyes, please understand, in premenopausal lady, that means a reproductive, the endometrium thickness varies from the day of the cycle. Immediately after menses, the endometrium would be only 2-3 millimeter. Close to ovulation, it could be 8 to 10 millimeters, and in the premenstrual period it could also be 14, 16, 18 millimeters. So no books will tell, it depends, because endometrium, you know, proliferative endometrium, secretory endometrium. So in a reproductive age group or even perimenopausal, there's no cutoff that beyond which I am thinking. It is a rule that whatever may be the endometrial thickness mentioned to you, always keep this point in mind, that I want to rule out endometrial hyperplasia and cancer first, and that is only possible with histopathology. So you will always do a DNC or endometrial biopsy first. Okay, is this understood to all of you? And the last point, which is a very important take home message, yes, so since it's a young girl and here you want to preserve the uterus, you want to preserve her uterus, we will give progesterone, and you repeat the biopsy after 2-3 months. Give her progesterone for 3 months, 6 months time, hyperplasia will revert back. Beta, there is no best option progesterone ka. Medroxyprogesterone acetate is what you generally give. So you can give MPA ka tablets, you can give DMPA injection, and LNG, IUD, or our Mirena also. All progesterones are equally effective, but the last point, progesterone is less effective if atypia is present. So atypia is present also is not a good thing, and atypia present, progesterone may not work very well. So therefore, since here there is atypia also and 48-year also, this IUCD and this progesterone I will not do. Okay. So beta Parth, again, if it's a 38-year-old para-3 living 3, all that, then you can still go with a hysterectomy also. Okay, so it's a young patient, then you take a chance and you counsel and decide whether you want to wait for 3-6 months and try. It's not that it is completely contraindicated. They will give you a clear-cut case. They will give you everything like this only. 48 भी है, atypia भी है, तो progesterone काम नहीं करेगा, and therefore the answer is simple hysterectomy. Okay, it's not that in 1 month it will become cancer. You can try progesterone. If it's a younger patient, you can try. Okay, is this understood to all of you? So I hope that helps all of you. And those who are joining in now, also better Dr. Meghna, Devaya, late. Okay, so yes, again, very important question. So we have got a primigravida in labor and delivered a baby, and the placenta is not coming out even after an hour. Okay, so is it pathological or not, and which of the following is the average duration of this stage of labor? Very good, very basic. It's again a one liner, like mug up thing. These are the values which you need to mug up. Okay, so all of you should know that we are talking about which stage of labor. Anybody? So what is the first stage of labor? Sir, first stage of labor is from true labor pains till full dilatation. What is full dilatation? What is full dilatation? Up to 10 centimeter. Okay, so from onset of pain till 10 centimeter, the first stage. Second stage is from full dilatation till the baby delivery. Third stage is the placental delivery. And anybody, placental delivery, and anybody, what is fourth stage? Fourth stage, very good. Yeah, Priyanka, but can you tell me how much? Very good. 1 hour. 1 hour observation period, both in primary multi, 1 hour observation period in the postpartum period. Okay, 1 hour after the placental delivery. Is this understood very closely? What do you observe? Anybody in this 1 hour, what do you observe? 1 hour observe means what? You look at the baby. Hello, baby. How are you? You look at the mother. What do you do? Okay, temperature उससे भी ज़्यादा, BP, okay, more vitals, okay, but yes, yeah, we are mainly worried about postpartum hemorrhage, so of course temperature pulse, yes, bleeding PV, we are worried about excessive bleeding, and we see whether the uterus is firm. How should be the uterus? Should be firmly contracted. Okay, after the delivery, uterus should be firm, very hard, like a cricket ball. Okay, yes, absolutely. Okay, Terry, that's the word used in the textbooks also. Okay, it should be very firm and hard, and it should be well contracted. So, of course, you check for temperature, pulse, BP, but we constantly palpate the abdomen. Okay, now please pay attention. The first stage could be long. Okay, so all of you, from the onset of labor pain till full dilatation, the first stage could be as long as up to 12 hours in primigravida, 6 hours in multigravida. Second stage is the baby delivery, that's the actual pushing stage. It could be around, this is the average time or the median time, 50 minutes, but 60-70 also okay, and around 20 to 30 minutes in the multigravida. Because multigravida always, she has had one baby delivery, she's experienced, and the space is also there adequate. So always in multi things are there. And the third stage is roughly around 15 minutes. Okay. And fourth stage also remains the same. So first and second stage, remember, is different in primary and multi. Average duration 15 minutes for both, and 1 hour is the standard. Don't make a mistake. Okay, those who are late also, Venkatesh, Tamita, Adif, Famna. Okay, very important 30 minutes lecture gone. Please go back and see the recordings for sure. Okay, is this understood to all of you? So 15 minutes.